Hello and welcome to the National Road Safety Partnership Program webinar, Prescription Drugs in the Mobile Workforce. How can we assess and manage the risk? For those who are members of the Australian Institute for Health and Safety, you receive 5 CPD points for attending this webinar. My name is Jerome Carslake, so you can jump to that slide now, please, Andrew.
Andrew, yep.
I'm director of the NRSP and its many active activities. To find out more, please visit our website, register for our newsletter, and you can even follow us on social media such as our LinkedIn page. Today's session, it's going to go for approximately 60 minutes. We have plenty of time throughout for discussion. We're also recording the session, and email will be following up 24 hours afterwards. The link back to it and to the PowerPoint as well, so it's always going to be available. We love to make these as interactive as possible, so please send through your questions, add them into the question box. Next slide, please, Andrew. And as we're going to go through, it's going to really help inspire and capture it. There's also a chat box, so you can sort of add some components in that as well. We're going to have 2 polls along the way to help inform the conversation. And we'll also be following up with a bit of a Q&A afterwards of all the questions answered as we've gone through from today's and the last webinar as well. So now, moving on to our presenters we have 2, which is fantastic, as you can see. We have Andrew Leibie joining us today. G'day, Andrew.
Good morning, everyone.
And we have Adjunct Professor David Allen joining us.
Hi, how are you?
So, to give you a bit of an overview of who our panelists are, Andrew Leibie has been working as a scientist and business professional in the field of workplace drug testing for over 2 decades. Andrew has presented and published a number of papers on aspects of workplace drug testing in both national and international drug testing forums. He's a member of the Forensic and Clinical Toxicology Association, as well as a member of the Royal College of Pathologists, Quality Assurance Program, and Expert Working Panel for Toxicology. So, big credibility there. Joining Andrew, we have Adjunct Professor David Allen at the University of New South Wales School of Population Health, Managing Director of Drug Alcohol Solutions Australia, and Managing Director for Sydney Occupational Health. To achieve this esteem, David has over 30 years experience in occupational medicine and is a leading authority on managing drugs and alcohol at work. He has an in-depth knowledge of drugs and drug use combined with practical workplace focus. And it's going to really make this a really informative session. So thank you so much for joining us, everyone. Over to you guys.
Well, thank you very much, Jerome, and good morning to everyone. Thanks for joining on. I guess the place to start when we're talking about prescription drugs is there's certainly a perception amongst a lot of employees and line managers that I've spoken to in the past, and even, it must be said, I think it's perhaps medical professionals and safety individuals, that if a drug has been prescribed, really, how bad can it be, right? There's been a doctor involved, there's been a pharmacist, it must be fine, right? Well, look, that's very much the case for the actual medical aspects of the drug, but when it comes to driver performance and work safety in higher risk industries, operating heavy machinery and high risk situations, unfortunately, there are a number of drugs that can have quite an influence on the ability to perform those tasks safely. And look, this is a very complex field. By no means, in this half an hour or so that we're going to be discussing before we throw it open to questions, are we going to be going into all of the minutiae of the factors involved. There's not only the rules and regulations around the drugs and how they're prescribed and how they need to be dispensed in Australia. There's also the fact that we've got individuals involved with their different experience and tolerance for the drugs. Certainly a number of these drugs are more of a risk when you first start taking them than if you've been taking them for a while. Individual metabolisms are going to play a part. If you're taking some of these drugs and you've got fatigue management issues, that's clearly another big area of risk. Taking other drugs, so one drug by itself might not be so bad, but 2 or 3 having similar types of effects can certainly affect your workplace performance. And a big one is the consumption of alcohol with a number of these drugs. You'll hear some scary stories later on about how much that can really change the risk profile for some of these medications. And I'm talking moderate amounts of alcohol here. I'm not talking about somebody on a bender. I'm talking about somebody literally having a couple of standard drinks. And then a great stat here from supplied by the NRSVP, which is apparently that even though a number of these drugs that are dangerous in terms of your driving performance will have a warning label on them, 1 in 4 people completely ignore that, which in some respects I'm perhaps surprised it's only 1 in 4, but I certainly don't find that statistic hard to believe, I must admit. So look, there are literally thousands of medications that are commonly prescribed around Australia. By no means are we going to go into all of them. Really, I guess there's a couple of points here where there are opportunities for intervention. So if you're sitting there looking at the risk profile for your fleet or for your workers, obviously all these drugs have to be prescribed, so that a doctor has to be involved. David will perhaps talk a little bit more about that later on. But there will also be a pharmacist involved. So the pharmacist has to prescribe all these things. You can't buy them, in many cases over the counter, or you certainly can't get them from Woolies. And so that means there'll be a warning label on, although we've just heard about how effective that may be. And it's by no means that all prescription medication is bad. Obviously, people need to take these drugs for whatever the medical condition is. But a number of prescription medications have actually been shown to be beneficial in terms of your risk profile when driving. And a classic case of that is antidepressants for especially somebody that's recently been prescribed, being diagnosed with clinical depression. When they start taking their antidepressants, their risk profile of driving actually is substantially reduced because their ability to concentrate on the road and less distraction and a number of other factors. So, the moral of this story is not to say nobody's allowed to take prescription drugs by any stretch of the imagination. It's to perhaps do a bit of a wave-top view of a couple of the major issues, and then certainly towards the end of the talk, some of the mitigation strategies and ways to improve or reduce the risk.
Andrew, sorry, just to interrupt. It just appears you're using an older version of the PowerPoint.
Right.
I can share mine and we can keep running with that if you're fine.
Sure. Yep. No, that's fine.
Sorry about this, everyone.
Do you want me to stop sharing?
If you could, please, that'd be great. There we go. Sorry about that, everyone.
Aha, there we go. We've got a better graphic.
Sorry.
No, that's fine. So, David, perhaps it's most relevant if you talk about some of the broader aspects of what we're talking about in terms of driver performance.
Yeah, so the sorts of things we're concerned about are drug classes like opioids and benzodiazepines and so on are impairing the ability of the brain to function and the body to coordinate. So the sorts of things as sleepiness, reduced reaction time, ability to react quickly to things, lack of ability to concentrate, tendency to fall or stagger, poor coordination, vision disturbance, and change in mood. So they're the sort of things that some prescription drugs will affect and cause increased risk of accident. Next slide.
So thanks, David. So I am going to reference alcohol a couple of times, simply because we know it's, we all understand the aspects of alcohol in terms of driving performance in particular. And obviously, the statistics are pretty well locked down for alcohol. The more you consume, obviously, the greater the risk. Having said that, what I want to talk about is I'm going to reference odds ratio a number of times in the course of the next couple of slides. The odds ratio is not an odds ratio of 5, for example, doesn't necessarily mean it's a 5 times greater risk of having an accident. It means that the odds that alcohol in this case was a contributing factor to the accident is about 5 times greater at a level of 0.05. Even though overall, if you look at 1,000 people, driving with a blood alcohol concentration of 0.05, their actual risk is about double. So risk and odds ratio are not the same thing. Having said that, the greater the odds ratio, the stronger the evidence is that drug or that combination of drugs is having an effect. And an odds ratio of less than 1 indicates a protective effect. So the antidepressants that I mentioned before typically have odds ratios of less than 1. So people that are driving them, their odds of being involved in an accident from that drug are actually reduced. So next slide. Thanks, Jerome. I'm getting that little bit of statistics out of the way. Now, I'm going to talk about 2 major drug groups. Both because they're very commonly prescribed, and both because the evidence is quite clear-cut for their effect on driving performance. So oxycodone is one. Oxycodone you may know as a brand name like Endone. Very commonly used in Australia, very commonly illicitly used in Australia, and unfortunately, the numbers aren't necessarily going down in the same way that the government would like. The number of prescriptions out there is really quite static over the course of the last couple of years. And this quite complex, busy-looking graph is from the National Wastewater Drug Monitoring Program. So you may be aware that a couple of times a year, the National Crime and Investigation Commission sponsors our analysis of our sewage plants around Australia to detect the types of drugs that are present. So if you're eating a drug, or you're injecting a drug, or you're smoking a drug, most of that gets eliminated in one of 2 ways, and both of those 2 ways end up in your sewage system. So we can actually measure the tiny amounts of drugs present in that sewage water, and it gives us a really good snapshot of the consumption of the drugs in capital cities and regional areas by state. So one very important thing about oxycodone, it's more prevalent in terms of per capita out in regional areas than it is in the cities, generally speaking, for most states in Australia. That is relevant when I'm talking about the regional areas. I'm not talking about back of Burke. In Victoria, you may see on this graph that the prevalence is much higher in regional areas. These are areas like Wangaratta, Mildura, Shepparton, those sorts of parts of the world. So major regional centres. In Queensland, it's places like Toowoomba and a couple other cities up the coast. New South Wales, it's things like Central Coast of New South Wales. So, still large population centres, and a lot of your employees, I'm sure, live and work in those areas. And oxycodone is incredibly prevalent. It's prevalent both by prescription, it's prevalent by illicit use, and it's prevalent by oxycodone being a painkiller. Look, I had a bad back. My doctor prescribed me some. Do you want to take some of my drugs, mate? Because they help my bad back. Why that is a danger, if we look at the odds ratio for oxycodone or Endone, most of the studies put it at an odds ratio of sort of 3 to 5, which is broadly speaking what we were saying for a blood alcohol concentration of 0.05, perhaps a bit less, but in that sort of order of magnitude. What is really important about oxycodone, though, is oxycodone and moderate amounts of alcohol. So again, I'm talking, I'm not talking someone on a bender. I'm talking about somebody that would be having a few beers after work. The odds ratio jumps to something like 21, 22 in some studies. So that's a very, very significant risk factor. Now, the person may be prescribed this drug. They may be literally only having a couple of beers, but especially if they are taking it for the first time, or if they've not exposed to this drug much previously, the odds ratio leaps enormously in that sort of scenario, as it does sometimes with other medications. Can I have the next slide, Jerome? And benzodiazepines. So benzodiazepines are another very, very commonly prescribed drug in Australia. When we look at workplace drug testing, urine workplace drug testing regimes, you'll typically get something in the order of 2.5%, 3.5%. Thanks, mate. 2.5%, 3.5% of all your workforce will have benzodiazepines detected in a workplace drug testing program. So that's hopefully that's all been via prescription.
Wow.
Some brand names are, you can probably see a few here on the screen: Alidorm, Serapax, Xanax. For some of you that are a bit older, maybe Mogadon,
Valium.
Valium, indeed, David. Thank you. So these really are sleeping tablets or anxiolytics. Anxiolytics is an anti-anxiety type medication, or the Valium that David was just mentioning for muscle spasms, back spasms, and those sorts of things. But there is a great grey market. People will go doctor shopping, as I said, go to multiple doctors to get multiple packets. Perhaps we've got a few points of the risk factors from these sorts of things on the right-hand side. A few quotes, real-life quotes that I've had given to me, which is, you know, I'm told I'm allowed to be fatigued at work, so I took a few of the Mrs. Sleeping tablets last night. Oh, okay, what were they? Oh, they're the blue ones. Right, you know, no idea of the dose, no idea of the drug. And if it's sleeping tablets, and they say, and again, another real life situation, somebody saying, I can't be fatigued at work. So it's 2 o'clock in the morning, I'm still running around like a blue ass fly. So I took a couple of the sleeping tablets so that I'd get some sleep before I started my 7 a.m. shift. Now, you know, depending on what that drug is, it could easily be having an effect, the type of benzo, it could be easily having an effect 8, 12, 24 hours later. So clearly that person is trying to start their shift while they've got a drug that's actively trying to put them to sleep. So we can imagine that that's not a great outcome. And especially if people are not used to taking these drugs. So if they've been prescribed before, but they've had a significant break, or they've been prescribed for the first time, or they've just grabbed a couple of Mrs. Sleeping tablets, the risk is much greater. Again, the risk of consuming these drugs with alcohol, they will actually have warning labels on the packet saying, warning, do not consume, this drug may affect your ability to drive, do not consume with alcohol if operating heavy machinery, and words to that effect. It's quite clear cut as a warning label, but of course, whether or not people are seeing that or not is another matter. And there is an illegal trade for them. So I think perhaps the next slide, Jerome, yes, is just, there's a whole host of different benzodiazepines out here. I'm not going to talk to this too much, just you can sort of see the range of odds ratios that are involved with some of these drugs are quite significant. You know, it's back up into that same sort of odds ratio type area that we're seeing with the blood alcohol concentration of 0.05 or the oxycodone. And most importantly, remember, this is just for people taking this one particular drug and nothing else. And as we start adding more drugs, and as we start adding more other things like alcohol, we're clearly going to change. These numbers are going to increase.
I'd add into that too. I mean, there's lots of these benzodiazepines. They've been around for a very, very, very long time, and they're considered to be very safe. The problem is they're highly habit forming, and of those people who take them for anxiety, most of them get into problems with addiction. And the second thing is they're everywhere. I mean, they're common. When we talk about commonly prescribed, over a 20-year period in Australia, there were 180 million prescriptions of these. And so we're roughly about 1 million or more prescriptions a year. That's 1 in every 25 prescriptions in Australia is for benzodiazepine. So, and what that means, and what I know from talking to patients, is that people keep these drugs in the medicine cabinet because they're good they help them sleep or relax, and they keep them for years, if not decades. So I'd be surprised if most of our audience couldn't find some of these somewhere in their house. If there's hundreds of millions of them out there, they're easy to access, and people hang on to them, and they're regarded as relatively safe, but they're a major issue for performance operating machinery and driving. And in combination with alcohol and other drugs, they're diabolical. And they're also very commonly present in people who've died of overdoses because they mix them. And people who take these, who've got habits with them or abusing them, tend to mix them with alcohol and other drugs, including narcotics.
And take multiple benzos as well. That's the other.
Yeah, and people who, and one of the treatments that's often given to people with alcohol problems is benzodiazepines. So people going through alcohol withdrawal are very commonly prescribed benzodiazepines to reduce the symptoms and withdrawal. So what do? They drink and take the benzodiazepine. Yeah. So it's a multiplicative effect on risk. It's dramatic, as Andrew was saying. I'll stop there for a moment.
Yeah. No. Do you want to just take over, Jerome, and talk about the polls?
Yeah, I'll just close it off now. And we have a second poll will be coming up in a tick. So just ending the polling now. And so this one was really on how much impact does impairing prescription medications have in your workplace? So I'll just share the results on that. So can you see them now? So just sharing the results. So
yes.
we had so a lot of people, I think we had one person said it doesn't affect them at all. There's some significant impact. On average, there's like 5. Considerable severe is one, and the vast majority, no idea.
And that kind of reflects unless you're measuring the use of them, or you're getting advice from your workplace on whether they're using prescription medications that could impair, you're just not going to know. So the scary bit is when they're combined with other drugs and with alcohol. That's when it gets really scary, or in someone who was what we call naive to that medication. So they haven't used Valium before, and Valium's one of the commonest prescriptions because the effects can last for over 24 hours. Someone takes their first dose, they don't realise that 24 hours later they're still impaired.
At least 24 hours, yeah, that's
right.
It
stays in the body for several days.
Yeah,
one tablet. It's and I say, unless you know the size of the problem, it's very difficult to know whether it's actually contributing to accidents. But it certainly measurably can.
And the best thing is, as we go along in the presentation a little bit later on, we thought we'd see this one now. We're going to touch on that, I guess, that workplace policy and fitness for work and those things a bit later on in this webinar. But it's just a great thought, because, and you'll hear these two experts will really touch on that, around what that should look like in an organisation. Which I think next one's a question. We've got a question slides next. I thought one that came through in the chat, and there's actually one I was thinking about as well, with regards to the DASA from John. Andrew, do you think the prescribers in some of these country areas, is it because I guess it's an older population out there, or they're a bit more liberal? What's your sort of hypothesis behind why this might be occurring?
Well, I won't give my hypothesis because I really don't know, but I'll give the couple of stories that are debated and thrown up. I don't think there's I haven't seen any conclusive evidence one way or the other. One thing that does tend to arise is there's an argument that it's harder to get access to GPs and pain management specialists, and maybe other allied health that can help with, if you've got back pain and those sorts of things. If you're out in the regional areas, there's just less accessibility to medical practice and allied health functions. So perhaps you get, you're more likely to get just prescribed something when you get to see your doctor for 4 minutes out in a regional area. David, do you have some thoughts on?
Yeah, I definitely do. And you'll find a different distribution even within urban areas. So you'll find that oxycodone use is associated with lower socioeconomic status. So it's associated with poverty and disadvantage. The further you get from the major cities, the less the access to care. So, rural areas, generally doctors are extremely busy and don't have much time. So, you may be more likely to get prescribed a tablet rather than a sort of a pain management program. And the other thing I'd say is once you start, and this is beyond the scope of this question, is that of those prescribed, say, oxycodone, 10% of them, like long-term for non-cancer pain, 10% of them get addicted. Between 8 and 12% of people who are on oxycodone or other opioids get dependent and addicted. So I think it's a mix of all those things. And there's a really good documentary that was on Netflix called The Pharmacist. If anyone's interested, it'll give you a perspective. And I think the parallels are definitely there with Australia. It's about the oxycodone epidemic in the United States. And the other thing is you'll find that there is a financial... what's the word for it? There's a financial incentive for some doctors, some minorities of doctors, to prescribe these. It takes roughly 30 seconds to prescribe a narcotic or an impairing drug if the patients are demanding them. And those patients tend to keep coming back to certain doctors who prescribe a lot of them. So, and that comes out in that documentary, The Pharmacist. So those are the things. And I guess lack of access to better pain management and physiotherapy and so on in rural areas.
Yeah, and it's interesting though, because you mentioned the US, but these sorts of statistics are mirrored in the US, where per capita oxycodone consumption over there, where they had a real problem, was again regional, not rural and remote communities, but smaller regional towns, the sort of ex-industrial heartland type places where there's a lot of higher levels of unemployment and those sorts of things.
Yeah,
so, good question. Wish I had a good answer to those. Sorry, John. But there's been lots of debate about it, but I've not seen anything quite that's really definitive to give a good explanation. And it's interesting because it's not the same in every state. Like in the majority of cases it is, but you look at some states and like Tasmania, for example, is pretty much the same in capital cities versus the regional areas.
Okay.
There's another question there that John's put in. Do you want me to address that?
Most certainly, go ahead.
So John, good question. It depends on the substance, but generally...
Can you read the question?
Yeah, the question is how long till tolerance occurs? So that generally within days, it'll start. And I mean, for benzodiazepines, the effect on anxiety, for instance, after a month, it's significant tolerance. So they're generally recommended not to be taken for more than 30 days. With narcotics, tolerance within days, and it gets worse over time. And so the tendency to increase the dose if it's used for non-cancer pain, opioids. So that's where people get trapped. And I'll also say that long-term use of opioids. So there are very few indications for long-term use of opioids and benzodiazepines. Very few. So of the 1.5 million benzodiazepine prescriptions in Australia, I suspect that a tiny percentage are appropriate, given that there are safe alternatives. I'll talk more about that later.
Question for you guys. So I was just reflecting on when you're talking around alcohol or taking a drink, and how it can be just like 1 or 2 glasses can impact, increase your risk ratio. Is there a time like you mentioned the time limit some of these drugs affect you? If you're taking it towards the end of that cycle, will it still have the same effect, or does it depend on the person?
It depends on the drug. Yeah, because some of the benzodiazepines, for instance, only last for a few hours, and some last for over 24 hours. And whether it's peaking in the levels going up in your system and peaking in your system, it's very complicated because the metabolism of benzodiazepines is complicated. Would you agree with that, Andrew?
Yeah, and you can actually find, Jerome, one of the other factors is in some cases the metabolism of the alcohol is trying to take place at the same area of the liver that the metabolism of the drug is trying to take place as well. So it can actually mean that the drug is going to stay in your system longer, and the alcohol will stay in your system longer. So that you have that's not common, but it's possible. So the other thing to put into this mix as well is fatigue. What we're talking about here, both with oxycodone and benzodiazepines, is really the central nervous system suppression. Right, it's making it harder to think. Some of those things that David mentioned before about ability to concentrate and quick reaction times are being suppressed by oxycodone and its friends, tramadol and fentanyl. You may have heard these drugs as well. As is benzos, as is alcohol, and as does fatigue. So you imagine you've got 2 or 3 of these things. Each in and of itself is not necessarily. I've taken one of these before and I was fine, but now I'm tired. Now I've had a couple of beers and I took a painkiller as well as my benzo, and you were talking a vastly different level of suppression of your CNS activity.
And you've got obstructive sleep apnea because you're overweight, right?
That's outside my remit, mate. That's
there's a combination, and nearly 70% of Australians are overweight or obese. And of course, that also is more common in lower socioeconomic groups and in rural areas. So obesity is much more of a problem there. So you've got a real cocktail of problems, so to speak, contributing to accidents. There's a question there from Sharon. What is the best way to manage the risk of drug influence with drive? We might deal with that.
Later.
Yeah.
And just to summarize that, I guess it goes right back to what you guys said at the very beginning. Like when you're taking these, just don't mix it. Like that's the key message. The complexity of it, of what you sort of said there in the summary is, I would say, just don't mix alcohol with on it.
And I also think you need to build in prescription medications and over-the-counter medications into your fatigue management system. Education on that.
I think we touch on a couple of these points in the next slide or two, Jerome.
It's
anyway,
a perfect segue to move on.
It is. Well, I need the. Oh, actually, yeah. So this is a good point. I think it's one of my last slides, and then it's sort of the David show. But workplace drug testing will, to a certain extent, detect these drugs. The ones that I've spoken to previously about oxycodone and benzos, but it's much less clear cut. So if you're talking about a urine drug testing program, you probably won't detect oxycodone unless you're specifically asking for it. The new oral fluid standard or new saliva standard for drug testing actually includes oxycodone for the first time. And that's largely because there was a concern that it maybe is becoming more prevalent, and it's quite easily detected. It's quite a robust detection method in saliva, but it won't be detected, as I said, typically in a urine sample. But benzodiazepines, generally speaking, won't be detected in a saliva sample, even though you may have an assay on your device. Just the way the drug is metabolized in the body means that almost none of it is present in the mouth. So the other problem is what do you do? I mean, and David's certainly going to talk about this in a bit more depth, but just because in some companies will say, look, yep, that's fine. As long as I've got a prescription, we don't need to worry about it. And I think that's perhaps a bit of a laissez-faire attitude, considering the risk profile some of these drugs can have. Next slide, Jerome. And because really what's been involved, that individuals had been to the doctor, been prescribed this drug. We know that they may not be reading the warning labels. We're hoping that the pharmacist told them about the fact that they shouldn't be driving. But if their job as a driver, have they told that to the GP when they're getting their prescription? Does the GP actually know what they do for a living? Do they know they drive a forklift? Those sorts of things.
And that's a good question. I'll just jump in there, Andrew. Like John asked as well, how do doctors make a judgment call on driving ability? Just to draw on that a little bit further.
Do you want me to answer that now?
Yeah, that'd be great. Thanks, David.
It's a very good question. I can't tell you how many doctors I've spoken to over the phone about patients or workers who are taking impairing drugs, and they've often write a letter and say this worker is not affected or impaired by this medication on a certificate of some sort. And when you ring them, and the classic thing, how did you assess that impairment? And the doctor says, well, I asked them if they were impaired, and that's what happens. That's the reality, and that includes GPs and psychiatrists. A lot of these drugs are prescribed by psychiatrists, by pain specialists, and I'm not sort of dumping on them, but doctors are not doing validated tests of impairment. They're not. I've never seen it done by treating doctors ever. Now, that's not to say it isn't done, but I've never come across it.
And it's important as well to consider what's going on here. A lot of people think that, their definition of impairment in the minds of most individuals is if I'm slurring my words and I can't stand upright and I'm stumbling around, that's when I'm impaired. That's not, these drugs aren't going to make you not walk a straight line, but it's when you need to react quickly, when you need to have a high level of brain function to solve a complex three-dimensional puzzle of what's happening in that road in front of you. That's what's impairing. That's the bit that's getting really sluggish and really hard to react quickly to. So if you're just driving 100 k's an hour on a dead straight road, you are not going to feel impaired. If all of a sudden there's something leaps out in front of you and there's another car coming the other direction and you have to react quickly, that's when you will be impaired. So that's where the risk rises.
Thank you, guys.
Next slide, I think, Jerome. I think it's all.
Yes. So it's talking about what workplaces need to do. So in your drug and alcohol policy, you need to reference prescription medications and over-the-counter medications, not just the illicit substances. So bearing in mind there are, thousands upon thousands of Australians walking around with benzodiazepines or opioids in their system and mixtures of them. The workforce needs to deal with it. So it's important to encourage workers who are in driving positions. And going back to the thing about doctors assessing it, the doctor says, "What do you do for a living?" Asking the right question. And that person says, "I'm a sales rep." They may not consider that person's a professional driver. So you need to drill down. Doctors need to drill down, and unfortunately, your typical consultation in a fast sort of a high turnover medical centre might only be 5-6 minutes. Those things often get overlooked. So in fact, it's very, very common that doctors don't ask what the person does. So hopefully the doctor's doing it, and then the pharmacist is doing it, and the other part of the equation is the workplace. So encouraging people to disclose if they're taking medications. And I mean, I'm talking about treat your workers in driving positions like athletes going to a significant event where they may be tested, right? So that, that they consider that safety is a really high priority. And so if they ever take anything from the pharmacy or from a doctor, they ask them, could this be impairing? And then they know if they have to take it, they talk to their workplace about it, so that that's confidentially handled and the risk is managed, and putting people on suitable duties if they do need to take these drugs. So training, I think this is part of any of your training programs on drug and alcohol and safety is, toolbox talks, e-learning, education sessions on understanding medications and alternative options. And like I said before, I suspect the vast majority of these prescriptions are inappropriate and unhelpful and unnecessary. So, for instance, opioids long-term for non-cancer pain has little or no effect on function. It's got side effects, and we know that people get addicted. They are not good. Opioids are not good for persistent pain. So if a person's taking long-term opioids or long-term benzodiazepines, remember, the anxiolytic effect of the benzodiazepines only works for up to 30 days. They're not recommended beyond that. So if they're taking these things, firstly, if they're taking them occasionally, they need to be educated not to do that or to tell someone. And secondly, that there are actually better treatment options out there for pain and for sleeplessness, insomnia, and so on. All right. So there's an opportunity. I guess I'm saying as an employer, you're interested in the health, safety, and well-being of your workforce. And if they're being medicated inappropriately for their pain or for their insomnia, actually, you can not only reduce the risk, but you can help the worker in their general health by educating them. Now, this shouldn't be up to the employer to do it, but it's part of the three sort of prongs of it. The doctor needs to play a role in it. You can't control that. You just can't. You can try, but it's difficult. Trying to get doctors to do things they're not accustomed to is trying to get cats to march in a parade or get smoke into a box. It's notoriously difficult. You want the pharmacist to play their role, and generally pharmacists are very good at that, right? At educating workers, assuming workers understand English well, which is an issue. And the third place is the third prong is the workplace, where they can influence, the workers' behaviours and medications. Did you want to say something, Andrew? Yeah,
just some like practical points. I know in the past, David, you certainly mentioned the idea of sort of like a card or something that workers can have. So when they're at the pharmacy, it can say, "Can you please tell me if any of these medications may affect my ability to drive a heavy vehicle or work safely or something?" And that can act as a bit of a prompt, at least at the pharmacist level, or ideally at the doctor level.
Well, doctor and pharmacy, that's right.
Yeah, you don't, rather than put the onus on the individual, because it's a difficult question for many people to ask. At least if they can have a card that they can pull out and say,
yes, yeah, give it to the pharmacist and give it to the doctor and have it in their wallet. So when they ever have to take any medication, they pull that out and give it to the health professional so that they know. And that reduces the risk if their English is poor or their literacy is poor, or they can't read. So, I mean, the last point there is it's complicated and complicated by personal factors of the person, their medical condition, their ability to understand information, or their motivation to do that. If they've got an addiction, they're not going to report. So there's a whole raft of things that need to be addressed. Next slide.
Yeah, on that as well, so just before we move on, I think that card for the role of description, it's almost would be like a great tool. So for any employer or anything like this, when you sign on, if you're driving, and because I think a lot of organisations overlook that driving for work purposes. Like you mentioned, a salesperson, for example, they may drive in a vehicle for 8 or 10 hours a week going between A to B to jobs, and that entire purpose and safety of that role is overlooked.
Correct. Yeah. People make assumptions about the job title, and that's often a trap.
And that'll be an easy thing for an organisation to do, like I mentioned, with that card as a support mechanism. So when you're going in and the onboarding. So but I'll move on now. That's great. Thank you.
So in terms of best practice for prescribing opiates and benzodiazepines for drivers, making sure if workers are taking them, it's obviously prudent to make sure they're getting it prescribed and they're not either getting it for a friend, family, or illicitly. Check their fitness for work. So talk to the doctor. If you can't get clear information, get them assessed by someone independent. Just determine whether they're fit. So again, if someone's on long-term opioids, long-term benzodiazepines, or occasional use, that look at whether it's appropriate, because in most instances it isn't appropriate, and there are better alternatives, better, safer, more effective alternatives. These are, opioids and benzodiazepines are what I would describe as dirty drugs. They have a role to play, but in many regards they're more trouble than they're worth. They're dangerous because they're so easy to obtain, and the effects of them can be so dramatic in terms of accidents and addiction. That it is a slippery slope once people start on these, as I've said. So sister worker to discuss with doctor and pharmacist an alternative effective if treatments that aren't impairing. I've already said that. Yeah. So we've talked about risk of accidents, fitness works. There is significant usage of these drugs. They're everywhere. As I said, 1 in 25 prescriptions in Australia is a benzodiazepine. So they're prevalent everywhere. If the substance is in someone's body, effectively, you can assume that they are potentially impaired. And if there's multiple substances, they're highly likely to be significantly impaired. These are drugs that can be abused, and that is a common problem. And I think that's reflected by the number of prescriptions. A lot of those people are habituated, dependent, or addicted to these substances. So it's important to review and your policy, keep it up to date, and ensure the workforce understands the risk. So that means lots of education, reinforcement, just as it is about alcohol. People need to be educated regularly and reinforce that education about the risks. Okay, that's all I have to say on that.
Now we're on to some questions, and we have quite a poll. We've got the poll. I'll leave it open just for another minute or two, getting one going through. And we've got some queries around resources as well. So I think I'll just start off with that one here from Emma saying, good morning. Do you have resources, flyers that can be used to send to employees for education on prescription medication? NRSP can certainly curate, and we have some quick facts and other things. Happy to share anything that Andrew or David, you guys may have.
Yes. Usually at the state government level, there'll be the drug and alcohol services, or while they have a bit of a focus on illicit drugs, they definitely will reference alcohol and prescription medications as like wall-mounted posters and some of that sort of information. But it's the ability to get in front of individuals, and as David mentioned earlier, you've got to consider English as a second language and literacy and those sorts of things, because it is a bit complicated.
I mean, I think basically the information and the education needs to permeate your workplace safety system and culture. You know, these things are before the days of drug testing. This was invisible.
Mm.
You know, people weren't aware of what was contributing to accidents, and to a large extent, it's still invisible. You know, and it's that, along with things like obstructive sleep apnea. Well, that's only become a thing in the last few decades. It's still a huge problem. 85% of those with OSA never get diagnosed. So, you know, you combine them with drugs and alcohol and so on, becoming more visible. I mean, there's the potential for fatalities and injuries. So it needs to be part of your safety system and your culture.
That's great. One question here, I guess, around from Karen. What type of herbal remedies can affect your driver?
Oh, that's a good question. With the proviso that when you start talking about things like herbal remedies, it's very hard to know in some cases what you're getting, especially if you're buying things off the internet and those sorts of things. You know, I've seen like weight loss products and you know, tonics to make you feel better, and actually contain ephedrine, which is the same sort of beast as methamphetamine or pseudoephedrine, which is now much more difficult to get at. But that's not available in Australia, but you can clearly buy it on the internet because it's quite common. I wouldn't have thought, David, unless you're going to have a different view, I wouldn't have thought in many cases that most of the herbal type medications would have, or herbal type preparations, simply because if they're being sold in Australia, there are some sort of TGA involvement, and if they start having effects on things like your driving performance, I would have thought they would have had to have that as a warning label.
Yeah, that's pretty true. I mean, there are some herbal, you know, treatments like valerian and so on used for sleep, but they don't tend to work very well. That's not to say they don't have an effect, but it's small. But again, the way we manage that is the same. If you're taking anything from a pharmacy or any type of tablet or pill, or you regard yourself as a safety critical worker, and you get advice.
Yeah, because you can, I mean, some of the older style antihistamines for people with hay fever, they can cause drowsiness, and you can get them over the counter from the pharmacy.
They most definitely cause drowsiness. That's right. They're used, in fact, prescribed for patients for sleep. So Mercendol contains doxylamine succinate, which is an antihistamine, which is used as a sedative, and people use it as a sleeping tablet.
And yeah, and you don't need a prescription for it. So it's, but you do have to get it from a pharmacy. So again, you know, some sort of intervention like a card or some sort of worker
Correct.
education.
Yes.
And with the cards and those sort of things, does that come from the doctor, or where's the best place to source those sort of cards that you guys speak to?
Workplace.
Workplace?
Yeah, you won't get it from a doctor. It'll have to be something sort of, and ideally with some sort of number that the doctor or the pharmacist, if necessary, can ring. You know, because they can say, look, I've been given this card. I need to understand a little bit more about what this person does. You know, in terms of their role.
I think it's best coming from the workplace, and that's. I mean, it's essential, really, if they're driving.
And this flows on nicely from here. One from John. When should patients self-report factors that interfere with their drivers, such as medication? Sort of draws on a bit further in that work policy.
Medications, if there's anything that could be impairing.
But, and I guess on that,
go on. Sorry.
I guess on that, it would be, even if they're not sure, like if you're not even sure, it'd probably be better just to be upfront and honest. Yeah.
Yeah, sure. If they're taking something that, you know, that they need to tell their doctor, show them their card, tell them they're a driver, and they can't have anything that's impairing, that should work. Tell the pharmacist and let work know. But if you hit it at several points, you're likely to be successful.
Yeah, and you know, the other thing here is we're talking about lots of people in lots of different situations and everything else, and everyone's going to have their individual roles and aspects. So it's very hard to have a one-size-fits-all policy. But you know, it may be that they can get some really practical advice. Look, the doctor says, I've got to take this drug for whatever reason, but you know, I've got to be really stringent. I've been told repeatedly now I can't drink any alcohol while I'm taking it, or I have to take this sleeping tablet, but I can't take it anymore. You know, I have to have a minimum 8 hours between taking it and appearing at work. You know, so it's not to say you can't have that drug. It's just got to be managed appropriately given the risk of your workplace environment.
Great. Should all drivers behave to the same standards, do you think? From John?
How do you mean behave? Sorry.
I guess it would be, my interpretation of the question, so all I've got is that to go off. It would be basically, I guess, it doesn't matter which sector you're in. My personal thoughts would be, yes, I think it should be one standard for everyone. All workers should be treated the same. And it would be, so like David made the point earlier, any drug coming in, declare that, be clear with that. And there shouldn't be any variance. My thoughts between heavy, light, grey fleet, wherever you sort of work.
I think if you just look at the risk, you do a risk assessment, and if they're driving, there's risk of fatality, killing themselves or others, whether they're in a car, driving occasionally or frequently, or a heavy vehicle. The risk is death, which is a very bad thing in occupational health. So yeah, essentially, I mean, you may want to apply your own sort of strategies to that, but still the same thing applies.
And I guess even on that, I think if you're impaired by one of the drugs as well, even if you aren't driving for work, if you're a pedestrian, it may fuzz your ability to cross the road safely. Because
it comes back to educating people about the value or lack thereof of a lot of these medications and the risks associated with them. They're, as I said, they're dirty drugs.
Yeah. There's a question here from John. He says doctors can use a familiar tool called MMSE.
Mini mental state examination. You could do that. It's not designed for this sort of context, and it really only is looking at cognition, not things like balance and coordination. So it's better than nothing, but not terribly sensitive.
Okay. That's great. And then a question here from Ron. I gather this goes back to the risk factor of, do some interpretation of this, Ron, so please let me know if I get it wrong. Are risk extremes mitigated by imposing zero BAC on all employees backed up by a testing regime? So I would gather my interpretation of that is if you just have zero alcohol whilst you're driving, if someone is using some form of medication, there should be no risk then of alcohol being mixed with it whilst working.
Yeah, well, that's true. I mean, that's a good point. I mean, if in most states, if you're driving a heavy vehicle, you have to be zero on the BAC anyway, right? So that's certainly going to substantially reduce that risk. But I guess the problem is broadening that out. If you've driven the truck back and you're having a beer on Friday night at work before you're driving home, is that still a risk? But definitely that in terms of fleet management and those sorts of things, yeah, that could be.
And I'll close our poll and share that as well. I'll end that. I've got about in the background there. So let's share this and see what sort of popped up as well. So we've got, when it comes to prescription medication and your fitness for work, which best describes your response? So we don't have any specific references or responses to prescription drugs. So we actually had.
It's a nice breakdown, isn't it? Yeah.
What are your thoughts, guys?
Oh, I'm pleased that there's so many people that genuinely do have a process of trying to engage with the workforce and trying to ensure that it is followed up. It's not easy. And if we go back to the last week's discussion when we were talking about medicinal cannabis and how in the US they're finding it, I say these are very resource intensive situations to deal with because you have to suddenly treat people as individuals and find out what's going on rather than just be able to say, great, no illegal drugs in the workplace. But look, I think that's ultimately where you've got to be at if you are, if you do have a large fleet. Remember, like I said, if you've got 2 or 3% of your workforce at any given day taking benzodiazepines and you've got, 5,000 vehicles on the road, that's a lot of potential risk out there.
Yeah. I would agree with that. I mean, a small percentage of a large number is a large number, isn't it?
That's great. And just a question here came through from Sharon. What are the WHS compliance requirements for the influence of prescribed drug use in the workplace?
Well, I would put that under general duty of care. You need to ensure the health, safety, and welfare. So it would fall under that. and I guess each workplace is going to be slightly different. So you need to assess the risk in the context of your workplace.
Excellent. Thank you for that, David. I'll answer that one live. So I guess just in sort of closing out, as we're sort of coming towards the end of the webinar now, are there any other sort of drug components that might sit on the periphery at all with just while we've got a little bit more time that should be sort of spoken to, or do you think, Andrew or David?
Well, we've touched on antihistamines, which are not prescription, but can sometimes be prescribed, and people take them sometimes for colds and flu, and they don't do much, if anything, for that. Some antihistamines are significantly impairing, and people pop them like lollies. I mean, there's also appetite suppressants, phentermine, and that are used for some drivers, frankly, likely as a stimulant, because for appetite suppression, they're only recommended for up to 30 days. And again, they're not very good. They don't work well at all, and I would never prescribe them.
Likewise, there's some prescription drugs for attention deficit disorder and those sorts of things, like dexamphetamine, and which is again a stimulant drug, largely abused, and it's one of those things that, because I think if somebody says, "Oh, look, I've got to take this, I'm being prescribed it, or I have to take it because of my medical condition," the first port of call really needs to be to make sure that person actually has a prescription for it. Any of these drugs we're talking about, any of the other ones, especially something that's popped up in a workplace drug testing program, there really needs to be good evidence for why that person needs to be taking that drug. And if they can't provide a prescription for benzos or phentermine or anything else, then it's in the same sort of category as cannabis or cocaine or methamphetamine.
Yeah, it's established whether they have a prescription. Second is whether it's indicated, and thirdly, even if it's indicated, whether it's being abused.
So that'll be length of time, repeat going through, maybe be a variety of doctors prescribing as well.
Yes, and I think, generally these people will have been under the care of a psychiatrist. But I mean, people who are, if they're in a driving job and they're taking dexamphetamine, as a doctor, my first concern would be, is it being abused? They're not great drugs to be taking.
And then driving. That's great. Thank you so much for your time today. One last sort of question. You're talking about the grey prescription in the market out there, where people are getting access to drugs and things are popping up. What's the sort of trend? Is that sort of increasing in Australia over time, or is it sort of tightening up? What's your sort of thoughts in that? Just for a ability for people to access these sort of things.
Yeah, well, just briefly on that wastewater analysis that's been conducted around Australia, because they sample sort of a couple of times a year and have been doing so for 4 or 5 years. There isn't always a strong correlation between what's happening in that wastewater management and what's happening prescription-wise. So everything got a bit changed COVID-wise, but certainly there was some evidence with fentanyl, for example, which is a drug similar to oxycodone, that the amount prescribed and the amount that's being detected in the wastewater, there was a lot more being detected in the wastewater than was being prescribed. So,
and that's not surprising. And these drugs are out there. I mean, anecdotally, there's stories of patients with cancer who are prescribed large doses of oxycodone, sometimes hundreds and hundreds of tablets at a time, because they've got severe pain and they're low income, and they sell them. They're selling them and getting $10 a pop for a prescription that might only cost them $20. So they might make hundreds of dollars out of one prescription. There's a huge market for that sort of thing, and the same goes for benzodiazepines. People will sell them.
Wow. Thank you, guys. I just thought it's really worth just highlighting the other part of why it's really important to make sure organisations have a workplace policy covering the fitness for duty, because of the ease of access and those sort of components that sit out there today. So big thank you to our presenters today. Just to let you know, reach out, get in touch if you want. As you've seen, they're both an amazing wealth of knowledge and real experts in this area. So thank you both.
Pleasure. Thank you very much for everyone's attendance.
Thank you.
And we'll be launching just a little bit of survey. We'll go out at the end of it. Please take the time to complete it. And as I mentioned, we'll summarise all of these questions into a Q&A, which will circulate out, and we'll gather in some other resources in this. So that will probably come in a couple of weeks. Thank you all very much for joining in and taking the time to ask the questions to these experts.
Okay, thank you, everyone.
Bye-bye.
See you guys now. I'll shut it down. Where's my end?